in terms of best approaches for molecular testing for patients with metastatic non-small cell lung cancer, there's different methodologies that could be used, and either plasma or tissue. So my approach generally is to look at broad molecular profiling, because we have now 7 approved targeted therapies for EGFR mutant lung cancer, matching the TKI to a great targeted therapy. So we have, osimertinib for EGFR, among others, alectinib and brigatinib for ALK, crizotinib and entrectinib for ROS1, selpercatinib for RET fusions, for really rare NTRK fusions, larotrectinib and entrectinib, and now capmatinib for MET exon 14 skipping mutations, and dabrafenib and trametinib for BRAF mutant lung cancer. So to capture all of those, I look at broad-based genomic profiling, next generation sequencing. You could look at tissue, you could look at plasma. There are pros and cons for looking at each one. If I need something fairly quickly, I often will send plasma, since you don't need to set up a biopsy if you need additional tissue, where you get the results in about a week. If there's a big surgical specimen sitting in the bank, that's a good one. I'll often use tissue. If where I don't have tissue, I'll often try first with plasma as I'm setting up a biopsy. Now, there are methodologies such as IHC and FISH that could be used for ALK and IHC. There is an FDA approved test. Those can come back fairly quickly. So there are certain situations where if I really suspect there's an ALK fusion, then I really need to start treatment quickly. I will occasionally send that as part of a targeted panel if in terms of timing to get the results quicker. But generally, I send next generation sequencing for broad genomic profiling.
My personal approach is to use both liquid and tissue next generation sequencing at the time of the diagnosis. I believe that those tests are complementary. Alternative approach would be to do next generation sequencing on tissue and save plasma NGS, or so-called liquid biopsy, for patients in whom tissue was insufficient. I wait until I have all molecular testing before I initiate therapy. In general, most of your patients with metastatic non-small cell lung cancer will also have PD-L1 testing done, and I expect that PD-L1 testing will come first before I have the results of the molecular testing, but I always wait for the molecular testing results before I start chemotherapy or any kind of treatment. Occasionally, I have to start therapy before NGS results are back because the patient's highly symptomatic, rapidly declining. In this case, I would recommend not giving immunotherapy with the first cycle. The reason to hold immunotherapy is to avoid emerging side effects such as pneumonitis if immunotherapy was given before tyrosine kinase inhibitors. I think if you think about testing for our patients with metastatic non-small cell lung cancer, first of all, we need to remember to test. There are several ways of testing for molecular alterations. In some instances, immunohistochemistry or FISH is appropriately for some instances, immunohistochemistry or FISH is appropriate. I use next generation sequencing, which has both a DNA and RNA capacity. And I know that some institutions will have a rapid immunohistochemical screen for ALK and NTRK and others. It doesn't really matter what system you use, as long as you use the system that assures that your patients with metastatic non-small cell lung cancer get tested for all the abnormalities that have FDA approval drugs for. NTRK, ALK, and ROS could be a part of NGS. Alternatively, you can order those genes separately. The most important thing when you decide what to test and what company to use is to check your platform. Like if you're using an NGS platform, make sure that the company that you're using is testing for NTRK. NTRK is new addition, and 3-4 years ago, we weren't testing for NTRK fusions. In my practice, I prefer NGS over single gene testing for 2 reasons. Number one, I believe that NGS testing saves tissue. And number 2, it's likely also save cost because now we have to test for 7 molecular abnormalities. And I think the cost will probably add up if you use a single gene testing. If you identified a molecular abnormality that has an associated targeted therapy, you should go ahead and treat. For example, if you use the single gene testing and you found that you have an EGFR mutation, I think that's enough for me to start treatment. Our patients with oncogenic drivers are unlikely to have both or 2 separate oncogenic drivers in the same patient. Those cases have been described, and at this point, we do not know, should we, let's say, go for ALK first or EGFR first, for example, for patients who have both of the alterations. So it is really not necessary to complete the NGS testing if you already know that your patient has an EGFR mutation. The NGS testing does give you some additional information. We know that patients who have, for example, a P53 mutation or RB1 mutation have worse prognosis than patients who don't have either, and they're also more likely to transform into the small cell lung cancer. So even though I'm not making any treatment decision based on that knowledge, I do find that for myself, it does give me some prognostic information. And also I might look for that patient a little bit more closely. Another tip that I have for next generation sequencing, if you have a patient who, let's say, are a never smoker, former light smoker, who have a higher incidence of having molecular abnormalities, and if you did not find it on your DNA-based next generation sequencing, you could consider RNA-based testing, which would be more sensitive for fusion.
It's such a great question to discuss the proper molecular testing paradigms nowadays for patients with non-small cell lung cancer, especially when many times we face situations when the tissue is somewhat limited or very limited. And fortunately, we have a lot of different ways to facilitate that effort, to enhance the completion of molecular testing, which ultimately is so critical to put our patients on the best treatment path and to achieve the best long-term outcome. So upfront, we want to make sure that we understand the patient's tumor the best, complete biomarker testing. Now, how do we deal with this situation of having potentially limited tissue? Well, issue number one is to make sure that we have good communication between members of the treatment team. And this is where a multidisciplinary tumor board is so important to educate each of our colleagues. For example, our pulmonary colleagues, we'll know very well that each and every time they do a biopsy, the biopsy might be needed for molecular testing. So they do their absolute best to, for example, do a number of different passes, build, a specimen that's cellular enough to allow molecular testing, even from a cytologist specimen, for example. Or the same way, interventional radiologists, will know that they need to take a couple of different courses, as long as that's safe from a particular patient, again, to allow the need for molecular and immune biomarker testing through the patient's treatment continuum. Still, of course, we'll face situations when what's obtained is just limited due to, for example, safety concerns. Very small, lymph nodes or nodules might just not allow much of a specimen to be obtained. Here, the next issue is, with the pathology department to ensure that there's appropriate tissue stewardship, that the tissue is prioritized for the testing that's truly necessary, as opposed to potentially wasting tissue for, let's say, immunohistochemical stains that might not be absolutely necessary. So both coordination and stewardship is very important. But lastly, we've been greatly assisted as of late through the development of ctDNA technology, liquid biopsy technology, where now if you have a patient with very limited tissue, where we cannot perform all the molecular tests, we can actually utilize this platform ctDNA testing to complement the tissue testing that we've been able to do. Dependent on the tumor burden of the patient, the stage of the patient, the yield of ctDNA testing will depend. But in a metastatic lung cancer case, now 70 to 80% yield is expected. So a fairly large majority of the patients will have informative ctDNA results, and they are strongly reliable enough to guide treatment For example, if we detect an EGFR mutation or metaxon 14 skipping, now we have strong data to say that yes, indeed, the patient should benefit from the targeted treatment just as much as if we had detected the same mutation abnormality from tissue-based testing approaches.